Thanks very much, Kamel. It's a great honor to be here, and I'm very excited at being in this part of the world. I really thank the organizers for inviting me. How do I move these things? Okay, thank you very much. Sorry about that. Okay, I'd just like to first of all state that anybody who wants these slides, because we are pressed for time and I've got a fair amount of ground to cover in 20 minutes, can ask me for them, so don't bother to take notes if they're of any interest. I'll provide the slides to anybody. This talk is pretty much... Do something. Okay. This talk is pretty much a kind of philosophical venting of spleen for me on a topic which I've had an interest in ever since I started working in blood transfusion, which I have to say is now 35 years ago. In some shape or form, I've always been in this field. And I started out working in a relatively under-resourced environment in which we collected whole blood, transfused it in bottles. We didn't have any plastic bags, and obviously we didn't have any component therapy. And to be quite honest, I don't think we killed anybody, and I think we did quite a lot of good. So I just want to view the retrospective over the course of, I guess, my career, that over the past 40 years, transfusion has evolved from the use of predominantly blood to now largely component therapy. However, we still see whole blood used in some circumstances, mostly in emerging economies and in military situations. Component therapy in the established economies predominates primarily due to resource utilization, the argument that you can get one donation to give you many products for many patients. We can discuss the veracity and the evidence of this argument and issues of safety. However, as has been said by Professor James, this change has occurred without any strong evidence of clinical outcomes between whole blood and component therapy, particularly in multiple trauma patients. Oops, I need to go back. Now, if I can just make a brief comment about the way transfusion services have developed in our developed social market, government-funded economies. They're basically blood services funded by the government. They provide transfusion needs through components, and very importantly, they've become embedded in the manufacturing inventory-driven paradigm, as I call it, and they have reduced blood services to the status of basically blood factories driven through GMP, quality control, etc., and extremely deplorably detached from the clinical environment. I have myself a background, 15 years of my career as a regulator. Obviously, I'm very strongly in favor of quality systems and GMP, but I think the primacy of blood transfusion needs to reside in clinical decision making as close as possible to the patient as is feasible. And this, I think, is very important to recognize in relation to the differences between the needs for blood in the developed and the developing world. Excuse me if I use terminology which is, I guess, somewhat less than optimal, but I'm an old man and it's the way I was brought up to use certain words. But if we look at this interesting set of data from the WHO comparing Benin and Denmark, and the relative transfusion rates in these two countries are not actually all that different, you can see that the population of transfused patients is obviously very different. And in relation to Benin, for example, the majority of blood transfused is used for obstetric hemorrhage and trauma-related hemorrhage, where I think it is fairly clear whole blood would be a better modality than components, whereas the transfused population in Denmark, like in most of the Western world, is of much more elderly patients receiving components primarily for elective surgery and cancer. Now, the emphasis is on fresh and on whole blood. So let's say something about the red cell storage lesion. Very briefly, you know all this from your textbooks, that the red blood cell doesn't like being out of the body. Things happen to it, and this is a brief summary of the kind of lesions which we are familiar with. I am always intrigued when people tell me, yes, but the 2,3-DPG drops, but it comes back after 24 hours. I thought the idea of blood transfusion was as much as possible to do good to the patient reasonably quickly and not have to wait for 24 hours for the oxygen releasing capacity of the red blood cell to come back to normal. This is an interesting controversy. And these slides are simply more of the same in relation to the summary of the red blood cell storage lesion. And as I said, you're welcome to the slides. I won't belabor the point. But I will make one more comment about the fact that the red blood cell has a pretty hard life. It's got to squeeze through very narrow capillary beds, and therefore the property which we've called for many decades, deformability of the red cell, is extremely important and is one of the first things which leaves it during storage. And this is data from other publications. This is a paper in Transfusion showing that red cell deformability and elasticity is markedly decreased as the blood is stored. I do not think that we need to have many clinical trials to show that basically this cannot be good. I question the need for clinical trials when the basic biology and pathophysiology indicates that harm is being given. We as a transfusion community have accepted now for 30 years the principle of precautionism, that if harm can be expected to occur, then it will occur. And therefore, I do not believe in subjecting patients to clinical trials as is being done at the moment to prove what is an obvious biological point. And however, we can subject, arguably, other creatures to clinical trials. And this is a very set of nice data from a paper, in this instance, one of a series of papers coming from NIH, Harvey Klein and colleagues, doing transfusion experiments in dogs and showing that old versus less old blood leads to markedly deleterious clinical outcomes before and after Staphylococcus aureus challenge. Very interesting publications. I wouldn't dream, of course, of trying to see the same experiments repeated in humans, but they give us good indicators. And this is from another study summarizing a lot of data, predicted risk of death against the maximum age of red blood cells. And it increases as the blood is stored. I believe now that I'm starting to merge somewhat into Professor James's data. This is showing the age of red blood cells is associated with bacterial infections in critically ill trauma patients. Not a good thing. And this is the interesting situation now of trying to attain the higher coagulation potential which is available in fresher blood using the higher FFP packed red cell ratios, which Professor James has eloquently, in my view, demolished very effectively. And you can see that, of course, you do get this decrease in mortality. And this is, of course, the data of Spinella et al., which has also been shown. However, we continue to belabor the point. Whole blood versus components. We get lower mortality. This is, again, the data of Spinella. So the evidence accumulates very, very markedly. Now, the concept has been developed, therefore, of reconstituting the whole blood, of putting together the various components in order to present the same hemostatic and other clinical benefits to the patients. And I question this on several grounds. First of all, in relation to the basic physiological input in terms of platelets, in terms of coagulation factors, in terms of red cell mass, the product as reconstituted is inferior. Secondly, although we do have highly effective, safe blood systems, I question the need to expose patients to more donors than is absolutely necessary in order to maintain an inventory of components which are inferior in quality. I think that this is something which needs to start being questioned markedly. And it's not just in the trauma of in the coagulopathy of trauma and in relation to massive transfusion and trauma. We have a lot of data now to show us that in other areas of massive hemorrhage, including obstetrical hemorrhage, we do gain the same benefits by giving whole blood, and this is just one set from some years ago. This is an interesting study in which the hemostatic potential of platelets following cardiac pulmonary bypass was compared in fresh whole blood and platelet concentrates. And the interesting thing is summarized by the final statement in the abstract, which is that the effect of 1 unit of fresh whole blood on platelet aggregation after CP bypass is equal or superior to the effect of 8 or 10 platelet concentrates. So why do we expose patients to 8 or 10 more donors than is needed? Now, this is my dear old friend and co-panelist today, and I've put this slide up not because he's here with me, although it's always a pleasure with me, but to give an illustration of this thing which I call the inventory argument. Because we know that there is the need to maintain a total inventory of fresh frozen plasma if you accept, which I don't, that fresh frozen plasma should be given in terms of massive transfusion and in terms of trauma. And therefore, some years ago in Australia, I was involved from the side of of being the instigator of requiring this to be done under a framework of some level of GMP in the preparation of liquid stored plasma for this purpose. I am not satisfied, Peter, and I welcome your comments on this, on the outcome, because as far as I can see, it focused entirely on the fact that this could be done in a quality environment, leading to adequate, whatever that means, levels of coagulation factors. And I don't think that that's what this is about, because if you look at this interesting study from John Holcomb's group, and again the military physicians, we know that towed FFP exerts protective effects on the endothelium, which are independent of coagulation factors, and these decrease during storage. And we need to keep this in mind. We do not know everything. Measuring coagulation factors in the lab is very easy, but it should not be a license to give inferior products to patients who need better products. I think we need to think outside the box. One of the areas which has always interested me is the possibility that actually we do keep blood refrigerated and maintain platelet viability, and it is the case that platelets do maintain better clot properties in the cold, although, of course, we know that they are cleared much faster. I would maintain that in trauma patients requiring an immediate hemostatic effect, this is of probably lower importance. So I just want to start winding down through reiteration. The bigger inventory, one donor, many patients paradigm has dominated our blood systems, and it has led to a huge industry in which we have blood screening with donor recruitment, millions of dollars, and large financial interests being involved. I would maintain that the primary driver in our blood economies and the social market systems has been the need for recovered plasma, which when I was but a boy was driven primarily by the need for hemophilia type concentrates. These nowadays are redundant concepts. And much of transfusion practice lacks an evidence base. We have encouragingly over the past 5 years generated several mechanisms whereby this can be improved, but I think we need to think very hard about imposing the traditional EBM paradigm on transfusion medicine to the detriment of patients. I do not believe that randomized clinical trials are the solution to everything. And in particular, the assumption that transfusion and resuscitation following massive blood clots requires individual stored components is redundant and needs to be challenged. Fresh whole blood has been rendered extinct in our blood systems, but is therapeutically superior. It is deplorable that it's been rendered extinct by a convergence of interests fueled primarily by my former profession, which has basically made it impossible to maintain and keep a whole blood inventory in a way which is clinically available. And I think that this is regrettable and needs to be revisited. We are now seeing the emergence of patient blood management, the emergence and establishment of patient blood management, and I think that this reflects the future of transfusion and can be achieved by closely integrating the transfusion service within the clinical environment, which I believe, from a state of relative ignorance, is very much the situation in your countries in this part of the world. And I implore you, do not give this up, do not make our mistake, do not generate blood factories, but go towards the situation that you have now and make it better, rather than copying a model which we have in our world, which is now very difficult to reverse. This is just one of the latest reiterations of patient blood management, and I round off for anybody who's interested with some references from my work and that of J.P. Allain and other colleagues, Steve Van Vakas, and the whole areas which I have been discussing with you. Thank you very much for your attention.